Hello everyone, we chose pre-contemplation and our category is smoking, and my name is Sky Phillips.
I'm Taylor Gamble.
I'm Chloe Armstrong.
And I'm Brianna Jordan. Smoking cessation is our selected topic because many individuals in the pre-contemplation stage may not yet acknowledge health risks associated with smoking or feel motivated to quit. This aligns well with the construction of the stages of change theory, particularly in the pre-contemplation phase. So our data to provide content is, according to the CDC, around 34 million adults in the US currently smoke cigarettes, with over 16 million suffering from a smoking-related disease. Prevalence rates are among the highest with low-income communities and ethnic minorities, demographics that often experience greater health disparities. Smoking contributions to leading causes of preventable deaths such as lung cancer, heart disease, and strokes. So here are some of our target populations, such as low-income adults from ranges through 18 to about 35, gender, both male and female, socioeconomic status, such as low income, race, ethnicity, focusing on group with higher smoking rates, such as African Americans, Native Americans, and the Hispanic populations. Our geographic locations are such as urban communities, and particularly those who rate among poverty who are limited access to smoking cessation programs. And the relevance to the topic is individuals in this population may have limited awareness and health consequences to smoking, making them particularly vulnerable in the topic. Social determinants like limited education, financial stress, and health education contributes to most low motivation to behavioral changes. High levels of nicotine dependence, normalizing smoking behavior with communities, and limited accesses to cessation resources make this population a priority for public health crisis. So, we have an overview of the stages of change theories. The stages of change theories explains how people change behaviors through a process that involves 5 stages. 1 is pre-contemplation. This individual is not yet aware of the needs to change or is unwilling to consider it. 2 is contemplation. Individuals to start recognizing the problems and consider making a change in the near future. 3, preparation. Individuals begin planning for behavioral changes, taking small steps towards the desired behavior. 4, action. Individuals actively modify their behaviors and work to adopt healthier habits. 5 is maintenance. Individuals continue their new behavior and work to prevent relapse.
Our assigned construct, pre-contemplation, is defined as where individuals are unaware of the negative consequences of their behavior, deny the need for change, or are not interested in making any changes. This stage is characterized by low motivation, minimal awareness of risk, and often external pressures to continue the behavior, such as social or environmental factors. In the context of smoking, people in the pre-contemplation stage may not see the harm in smoking or may perceive it as socially acceptable or stress relieving, making them reluctant to quit. Individuals in this stage often respond to messages that raise awareness, provide education about the health risks associated with smoking, and create a cognitive shift in thinking that makes them more receptive to behavior change. For smoking cessation, the pre-contemplation construct aims to address the lack of awareness and low perceived susceptibility to health risks associated with smoking. Interventions focusing on increasing awareness through educational campaigns, emphasizing the health consequences of smoking, and using motivational interviewing techniques and behavior coaching to encourage individuals to consider quitting. This contract fits within the broader stages of change theory by acting as the initial stage and moving individuals from inactivity or denial towards the next stage, contemplation, where they begin considering change. To begin the literature review, smoking is defined as the inhaling of smoke from burning plant materials, and specifically for this presentation, we'll be focusing on the inhalation of nicotine. This negative behavior is enjoyable and addictive, making quitting significantly more difficult after starting, and more extended use of the drug is a higher risk for illnesses like cancer, stroke, lung disease, and poor cardiovascular health. Smoking is a public health epidemic based on 3 key factors of peer pressure, addictiveness, and prominence within younger generations within different socioeconomic classes. These factors can help us understand the prevalence of smoking and allow for a tailor-made intervention for a specific age group, 18 to 35-year-olds. To begin, research by Pennsylvania State University indicates that peer pressure is one of the most significant causes of initial use of negative behavior like smoking and creates the beginning of smoking habits. In addition, studies within the National Library of Medicine confirm this by indicating that peer pressure is one of the number one contributors in young adult smoking initiatives, and intervention plans focusing on mitigating the effects of peer pressure can curb the amount of 18 to 35-year-olds that develop nicotine dependency. Knowing this, intervention plans raised around saying no to peer pressure and equipping preventative behaviors can restrict the number of new smokers within the target age group and lessen smoking rates. Smoking tobacco releases a chemical called nicotine, something highly addictive to the body and pleasure centers of the brain. Once inhaled, nicotine releases dopamine, a chemical associated with happiness and pleasure, alternating a person's mood and causing temporary happiness. The Center for Addiction and Mental Health, CAMH, compares that rush to that of cocaine and opioids, stating that the rush is a crucial component in its addictive nature. Nicotine is a substance that a tolerance can be created for, and therefore can require more consumption of the substance to get the same rush and effects as the first engagement. This negative feedback loop can lead to consuming lots of nicotine for the same effect and lead to a spiral of harmful behavior dependency. Focusing an intervention plan on the addictive nature of smoking tobacco and ties with the cost of the addiction can deter new users and help assist with early quitting. Lastly, the graph demonstrates that our age group 18 to 35 and the primary age group is the primary age group that is cigarette dependent. However, this graph does not reflect different socioeconomic classes and the social determinants of health that can positively influence or negatively influence smoking. According to the American Lung Association, people in rural environments, low-income individuals, and indigenous communities are a part of the top 10 communities disproportionately affected by smoking and tobacco usage. People in rural areas are more likely to engage in smoking earlier and smoke more tobacco, leading to a critical dependency of the drug. Lower-income individuals are the target for tobacco and smoking company sales, having more tobacco realtors within low-income communities and public housing developments. Indigenous communities have the highest use of smoking tobacco concerning race and ethnicity within the United States. These different structural and community behaviors must be reflected within different groups at risk for the negative behavior. Focusing on equity rather than equality, this high-risk age group, in combination with other high-risk communities, can significantly reduce smoking behaviors and must be considered within intervention plans. Lastly, focusing on these three factors, how different communities disproportionately suffer/engage with smoking, and using the community is vital in mitigating smoking behaviors in the pre-contemplation stage. Based on an article from Columbia College, community-based prevention efforts and education are the most effective regarding public health intervention. Smoking cessation programs must work with different communities and actively engage and connect on a personal level. The design intervention plan focused primarily on community health, equitable health education, and strengthening social resources and quitting tobacco use. The second part of this literature review deals with the social ecological model and how it relates to smoking. This approach to smoking can highlight different social determinants of health and how they impact the individual, especially concerning access and engagement with negative behavior. This graphic summarizes most factors responsible for tobacco use and the different concepts of concerns when providing intervention and mitigation support, specifically education, the healthcare system, all the way down to socioeconomic status, attitudes, race, and genetics. Using interpersonal, community, and societal engagements can help inform populations of the harmful and addictive nature of smoking cigarettes and why it shouldn't occur. Using this guide to identify contributing factors can allow for dynamic and diverse educational methods, ensuring everyone can be enlightened about smoking dangers and share the information within their respective communities.
Hi, I'm Chloe, and I'll be talking about our research summary. For our health issue and target population, it focuses on smoking cessation among individuals in the pre-contemplation stage, characterized by low awareness or resistance of quitting. For our insight and intervention, we formed three. For our first one is motivational interview, which is non-judgmental counseling to explore motivations for change and emphasize long-term health benefits. It also encourages self-awareness while helping individuals transition from resistance to contemplation. For our second is digital tools, Mobile apps and text messages provide personalized information and habit tracking without immediate pressure to quit. It also is effective for younger populations while increasing reflection on health impacts. For our third is community-based programs. Peer-led discussions and healthcare professional interventions build supports network by incorporating real-life success stories that enhance relatability and self-efficacy. Combined strategies progress 27% of pre-contemplation smokers to contemplation and 12% into the preparation stage. For our key insight, behavioral changes in pre-contemplation depends on fostering motivation through personalized supportive interventions that align with their readiness for change. And these are some of the sources that we used in our research summary.
So for our intervention plan, the intervention will be held at community centers in low-income urban neighborhoods, which are accessible and familiar to our target population. So additional components such as outreach campaigns will also be conducted in local clinics and through mobile health units that can reach areas with limited healthcare access. So some of our goals and objectives are to increase awareness, promote health education, and encourage consideration of cessation. And some of the activities that we have planned are educational workshops. So these workshops will be held weekly at community centers, focusing on the health risks of smoking and the impact on the individual's health, family, as well as community. These workshops will use visual aids, personal stories, and interactive discussions to make the health risks relatable and real. So some of the roles: public health educators will lead these workshops, while counselors will facilitate discussions, answer questions, and address concerns. We also have a motivational campaign. So a public awareness campaign will run concurrently using flyers, posters, and social media ads that will highlight the dangers of smoking, particularly among these low-income groups. Messaging will focus on dispelling myths and common misconceptions about smoking's health impacts, encouraging participants to rethink their smoking behaviors. Health communication specialists will design materials, and community health workers will distribute them and engage with participants to gather feedback. So our potential budget, with a budget of $100,000, here's how the funds will be allocated. So $40,000 will go to staffing, which will cover the salaries for public health educators, counselors, and the community outreach workers. $15,000 will go towards materials, which would include developing brochures, posters, and digital ads for the campaign. $10,000 will go towards venue and equipment, which would be used to rent space at community centers and provide the equipment like projectors, screens, seating. $20,000 for marketing, which would be used for online campaigns, printing materials, and outreach activities. $10,000 for incentives, which would provide like gift cards or transportation vouchers to encourage participation. And $5,000 for evaluation tools, which would develop, implement surveys, data collection tools, and follow-up resources to measure the impact of the intervention. So we would conduct pre and post surveys to measure changes in awareness and readiness to quit smoking. We would use focus groups to gather qualitative data on participants' perceptions of smoking risks and attitudes towards cessation, track metrics such as self-reported smoking frequency and participants' expressed interest in future programs. And we would also evaluate progress based on the goals and objectives, adjusting strategies as needed to improve our intervention outcomes. Research indicates that stage-based educational campaigns focus on increasing awareness of smoking-related risks have been successful in moving people from pre-contemplation to contemplation. Incorporating motivational interviewing as a technique has shown effectiveness in helping individuals acknowledge the downsides of smoking, making them more open to considering to quit. And interventions implemented in community settings like clinics, social centers, and community centers can reach individuals in the pre-contemplation stage effectively by using face-to-face outreach and culturally relevant messaging.
In conclusion, the proposed intervention aims to transform low-income smokers from the pre-contemplation stage to the contemplation stage by focusing on increasing awareness of smoking-related risks. The application of the stages of change theory ensures that the interventions align with participants' readiness for behavioral change, emphasizing awareness and initial motivation rather than immediate cessation. This approach is tailored to meet the specific needs of the target population, incorporating culturally sensitive messaging and community engagement. The intervention's potential public health impact is significant, as it seeks to reduce smoking rates among low-income populations by promoting a cognitive shift towards behavioral change. By improving awareness and creating a supportive environment for contemplation, the intervention addresses a critical gap in smoking cessation efforts. Final insights and call to actions involve engaging individuals in the pre-contemplation stage in both challenging and essential for long-term success. Continued investment in awareness campaigns, community-based education, and culturally sensitive strategies is crucial to drive sustainable behavioral change. For public health stakeholders, the next step involves scaling similar interventions, ensuring consistent community outreach, and monitoring progress to adapt strategies as needed. Empowering communities through information and support remains a key priority in achieving lasting public health improvements.
These are the literature review references, including graphics and APA 7 format.
Thank you for listening to our presentation.